Good afternoon, everyone. I am Dr. Timothy Adams, and I'm a board-certified colorectal surgeon and general surgeon who works here at the Kaleida Health System. I will be speaking to you today about colon cancer as well as colonoscopies. Any questions that you may have, I believe we have the technology where you type them in and we will sort of go through those questions at the end of our discussion here today. So the goals of the lecture today are to sort of outline who gets colon cancer and the prevalence, as well as some of the factors that are associated with potentially developing colon cancer and the association with polyps. We will discuss during this conversation the need for screening as well. This is just sort of a drawing here. It's busy, but I just want you to focus on the picture on the right. That's a picture of your colon. I get questions on, do colons only exist in females, or do only men have colons? But both men and female have colons. And this is how it looks on the inside. The picture depicts or shows the colon is separated into essentially three basic parts. There's a right side, a middle that sort of crosses over, and then a left side. At the very end, you'll see the word rectum written, and that's our rectum, and it finishes off as the anus. This is what we are looking at when we're performing a colonoscopy. Our goal is to look at every inch of that structure there. Colon cancer is the fourth most frequently diagnosed malignancy of both male and female sexes. Worldwide, there's approximately 1 million people who will develop colorectal cancer annually. In the United States, that approximates about 150 to 170,000 people each year. It was the third most common cause of cancer death in the world, and now it has moved up to number 2. In the U.S., it's the third most common cancer in both sexes and the second most common cause of cancer death overall. The overall probability of developing colon and rectal cancer in one's lifetime in the United States is anywhere between 4 to 6%. It is predominantly a disease of older individuals. Approximately 90% of cases are diagnosed in patients that are over the age of 50. Although in 2020 there were numbers that were calculated that showed approximately 18,000 new cases of colon cancer occurred in patients under the age of 50. Just showing you that colon and rectal cancer can occur at any age. The incidence of colon cancer is more than 40% higher in men than in women. And the ratio of rectal cancers, you'll often hear us refer to this as colon and rectal cancer. We sort of lump the two together, although they behave slightly differently. It's not better to get one cancer over the other. They just behave slightly differently and therefore have different therapeutic treatments or different approaches. But colonoscopy is equally as effective in identifying both colon and rectal cancer, which is why we group them together. For women, the ratio is approximately 3 to 1 compared to males, which is 2 to 1 when it relates to rectal cancers alone. We've seen a decrease in the incidence of colon and rectal cancer since the time of around 1985 of approximately 2% per year, and that's in direct relations to the colonoscopies that we are constantly talking about and encouraging patients to undergo. This reduction, though, seems to have been isolated or confined to the Caucasian race. It is largely limited to the left-sided cancer. So what that means is when you go back to that structure that I showed you, where I said the colon is divided into a right, a middle, and a left side, the main area where we've seen the biggest decreases in colon cancer is on the left side of the colon. We haven't seen that same decrease on the right side. There are a lot of different theories, but no absolute reasons or explanations to why that is. We know that there are differences in incidence related to your race as well as your nationality. We know that Ashkenazi Jewish populations will have a slightly higher risk of colorectal cancer. We know that the incidence is also higher in African Americans when compared with Caucasians. We know that the incidence of colorectal cancer in North America, Western Europe, and Australia occur at higher rates, while they occur at much lower rates in Africa and Asia. We're going to discuss some of the factors behind that, and it can really be reduced to sort of dietary um, changes that we see, as well as physical activity, obesity, alcoholism. Dietary fat has been sort of a high association with colorectal cancer. We know that we can see this in patients who are overweight. We can see this in patients who have a high dietary fat intake. That sort of correlates with red meat because red meat also has a high quantity of fat. You can get lean meats, but when you're looking at fatty intake, most people who have elevations to the fat in their diet usually are meat eaters. The way you may prepare your meat, barbecuing versus baking may play a role in the incidence of who gets colon cancer and who doesn't. Barbecuing your meat may have a increased incidence of colon cancer in those who barbecue versus those who do not barbecue their meat. We know that patients or people who have a higher intake of fruits and vegetables, essentially a higher fiber diet, seem to have a lower incidence of colon cancers. Going back to that slide where we showed the differences between Western Europe and westernized civilization versus Africa and Asia, one of the major differences in our diets is the amount of fiber that we consume. It's no surprise that we see a lower incidence of colon cancer in communities that eat higher quantities of fiber. Calcium has been shown to be protective. Folate has been shown to be protective. Alcohol consumption. We have seen a higher incidence of colorectal cancer in patients who consume approximately 2 or more drinks per day. And those numbers are always hard to isolate because there are many factors that are also contributing as well. But trying to separate each one of these individual factors have proven very difficult. So we just know that there seems to be a higher association. But that number, 2 or more, is not an absolute number. There's some information that would suggest that using aspirin every day can decrease the risk of colon cancer. But one of the reasons why you will not see your doctor essentially recommend the use of daily aspirin as a preventative measure is simply because there are also side effects that aspirin has, such as gastritis or stomach upset, ulcers and bleeding. And you always have to weigh the risk versus the benefits. And right now, we're not quite sure how much of a benefit the aspirin will play, but we certainly do know of some of the side effects of the aspirin. So that's an ongoing discussion, but as it stands right now, we are not telling our patients to use aspirin every day to prevent colon cancer, but something interesting to look forward to possibly in the horizon. We know that women who are on hormone replacement therapy seem to have a reduced risk of colon cancer as well. We're not sure what the relationship is, but it is certainly something that we have observed. Being overweight has an increased risk, and that goes back to your diet. Usually if you're overweight, you're eating foods high in fiber, high in fat, low in fiber, probably consuming red meat. And all of these factors play a role as it relates to the incidence of colon cancer in our communities. Physical activity. We don't emphasize this enough. I know that when I'm talking with my patients, I will sometimes forget to emphasize the importance on daily activity. Increasing your physical activity each day. Doing only 30 to 60 minutes of activity a day can decrease the risk of colon cancer as well. So we know that our sedentary lifestyles, combined with our diets and our obesity, all add up to a higher incidence of colon cancer. Smoking can increase your risk 2 to 3 times from tobacco use, along with many other negative findings that can happen with smoking consumption. Family history certainly plays a very big role in developing colon cancer. Those patients who have a first-degree relative, a mother or a father, a brother or sister who has colon cancer, have a higher incidence, potentially twice the risk of developing colon cancer themselves. Having multiple second-degree relatives also puts you at a higher risk. Age does play a role. So if you have a mother or a father, sister or a brother who has had colon cancer, but they were diagnosed over the age of 60, the information's not as clear-cut on what to do for that patient population. As it stands right now, the recommendation is that we sort of treat them as we would anyone else. And it's only for those who are less than the age of 60 that those risk factors start to increase, and that starts to change how we would recommend colonoscopies. We will come back to that shortly. We know there's a disparity between Caucasians and African Americans. We know that African Americans, as we mentioned earlier, have a higher incidence of colon cancer, as well as the stage with which they're diagnosed is usually at a more advanced stage than our Caucasian counterparts. And this probably has a multitude of factors that play a role in this, from our diet. Again, we have a westernized diet. Rates of obesity, smoking, lack of exercise, alcohol consumption, lack of access to the healthcare system, all can play a role in those numbers. When you look at the rates in, for instance, South Africa, the rates are 5 in every 100,000. Yet in African Americans, it's 50 to 60 in every 100,000. And the big difference will most likely be those lifestyle factors that we mentioned. African Americans, we know, have a worse survival rate, and mainly that's going to be due to being identified at a more advanced stage. And although the incidence among people 50 and older have declined over the past decade, we have seen the incidence in mortality be highest among our African American counterparts. As we mentioned, some of these disparities can be related to access to care. Screening rates have been known to be much lower in the African American community, and that could be secondary to a lack of access to the healthcare system in underserved areas. There's a lack of awareness. African Americans with a family history of colon cancer seem to also be less likely to be screened for themselves. For some reason, we've seen a higher incidence of colon cancers on the right side in African Americans, and that leads to a poor outcome as well. So how do we level the playing field? How do we make it so everyone can have successful outcomes? Well, we try to catch things at an earlier stage. We don't want to catch things at a later stage. So colonoscopies play a very big role in getting these cancers identified earlier, and even more importantly, preventing these cancers. We recommend in the African American community that they start getting their screenings at age 45. The interesting thing is, over the past 2 years, what we've noticed from the American Cancer Society is that that recommendation now crosses both races. So everyone right now is being recommended to get their colonoscopies at the age of 45, and 50 is no longer the recommended age. Improving access to the healthcare system can also help to level the playing field between African Americans and Caucasians as well. So screenings, there are multiple techniques for screening, but we're going to focus on the ones that are most commonly performed and the ones that are held with highest regard. So colonoscopy is the one that's the gold standard, and we're going to talk a little bit about that. There's a new test that's been around for a couple of years called Cologuard, which a lot of our primary care doctors have started using a little more frequently. And Cologuard is not a substitute for colonoscopies. Cologuard definitely is easier in the sense that it's just a test where you sample the stool and it looks for certain DNA factors in your stool to see if you have colon cancer. Statistically speaking, Cologuard is 92% successful for identifying colon cancers, but only approximately 40% successful for identifying polyps. And that's a big difference because we're trying to figure out ways that we can prevent colon cancer, not just catch it at an earlier stage. And that's where colonoscopy comes into play. Colonoscopy allows us to identify polyps long before they turn to cancer, and therefore has a better success when it comes to preventing cancers as opposed to just simply identifying them. Of course, colonoscopies can also identify cancers at an early stage as well, but the name of the game is preventative medicine, where we are actually trying to stop the cancer before it ever has an opportunity to exist. Cologuard can be utilized, I think, most effectively for patients who either are unable to undergo a colonoscopy or for patients who are unwilling to undergo a colonoscopy. But for all other people, the colonoscopy is the thing or the test that allows us the best success for catching polyps before they turn to cancer. In other words, again, preventing cancer development. Barium enema is no longer utilized just because of the better tools that we have. There is something called a virtual colonoscopy. And a virtual colonoscopy is essentially a CAT scan. You still have to do a prep for it, so you still have to drink fluid the night before. And you go to the radiology department in order for them to perform a CT scan to identify polyps within the colon. The setback to the virtual colonoscopy is that once a polyp is identified, then you'd still have to undergo a colonoscopy in order to remove it. So again, virtual colonoscopies are not a substitute for colonoscopies, but should be reserved, again, for patients who either cannot undergo a colonoscopy or, again, for whatever reason, refuse to have it. Here's an image of what a virtual colonoscopy would look like. We'll kind of give a caricature a little bit later of what a real colonoscopy would look like. So who should get colonoscopies? Everyone should get colonoscopies, but age does play a big role. We mentioned earlier that the age recommendation is 45 years of age or over. Again, for those who have high risk factors, such as a first-degree relative who has colon cancer, we would recommend that they start their screenings between the ages of 35 to 40. If you have multiple family members with a history of colon cancer, you would also want to start your screening at the age of 35 to 40. The colonoscopy, the hardest part of the procedure actually is the night before. Most patients seem to be very nervous about the colonoscopy because I think they envision just a very horrific experience in the endoscopy suite where we perform these colonoscopies where you're just yelling and screaming and you're in agony, but that's really not the case at all. The hardest part to a colonoscopy is getting prepared for the colonoscopy, and it's drinking the fluid the night before, where you're also not allowed to have any solid food either. So you have a tendency not only to be very hungry, but also very frustrated because you've been moving your bowels throughout the evening and you're also not able to eat, so you become very hungry throughout the day as well. You come into the colonoscopy suite, what we refer to as the endoscopy suite, where you're greeted by nurses and you go to the holding area where a small IV is placed into your arm, which will allow us to provide you with sedation. We then wheel you into a very quiet room where there's only 2 or 3 people present. The lights are dimmed and the sedation is given. While you're sedated, we perform our colonoscopy, which only takes somewhere between 15 to 25 minutes, depending on the length of the colon and the number of polyps we may identify. I have a picture in front of me of what a polyp would look like when we see it. It sort of hangs off of the colon, and we can easily remove that polyp And thus, by removing that polyp, we have prevented the development of colon cancer. We know that all colon cancers start out as that little polyp you see before you. Not all polyps develop into colon cancer, but all colon cancers start out as polyps. So when we perform our colonoscopy and we see these polyps, we can easily remove them. You don't feel them. You don't have any lingering effects afterwards either. There's no abdominal pain or pain with bowel movements or any lingering unwanted effects after the colonoscopy, besides maybe a little stomach cramping. Pretty much you feel like you felt before you came into the endoscopy suite, and you're happy because now you get to eat. And after the procedure is completed, you can eat whatever you want. We simply ask you not to perform any driving or working with any heavy machinery until the next day. And as a matter of fact, you can get back into the full swing of things the next day. And that includes going to work or participating in any physical activity that you would like. Depending on what we find during that colonoscopy and depending on your family history and your personal history would determine when your next colonoscopy would be. For those who have a clean colon and have no identifiable polyps, they're good for 10 years as long as they don't have a family history or personal history of colon cancer. For those who have polyps that we remove, well, we may want to see them in 5 years and sometimes sooner than that, depending on the number of polyps that we see and, of course, the size of those polyps. At the end of the procedure, again, you feel elated because you're just happy that it's over, and you will hopefully only have 10 years before you would need to have it repeated again. At this time, I'd like to take any questions that anyone would have regarding colon cancer screening. Let's see. I'm going to try and read the handwriting here. If they find cancer during a colonoscopy, do you have to have surgery? Yes. So colon cancer, and that's one of the major reasons why we like doing colonoscopies, to prevent colon cancer. Because essentially, once the cancer is identified, there's only one resolution to that problem, and that's surgical intervention. Now, there are many different ways we perform surgery, from laparoscopic surgery to robotic surgery, which are different ways of performing small incision surgeries. But not everybody's candidates for the small incision surgery, so we also have to use the big incisions as well. But regardless of which technique that we use, regardless if it's a small incision or a larger incision, the recuperation can be difficult. So surgery is a big deal. And so preventing colon cancer so you don't have to experience that aspect is very important. Common questions we get are related to the need of a stoma, or what we call a bag to poop into. Some people may know it as an ostomy as well. And not everyone needs an ostomy just because they're having surgery for colon cancer. But there are certain circumstances where it demands a temporary ostomy and at times even a permanent ostomy. If you have a history of colon cancer, at what age do you have to start screenings? Well, again, that also depends on the age of the person in your family who has it. So for those who have a first-degree relative who has colon cancer, we would recommend that you get your first colonoscopy at the age of 35 to 40, or 10 years younger than your family member was when they were diagnosed with colon cancer, whichever number is younger. So for example, if your brother was diagnosed at 35 with colon cancer, or your father or mother was diagnosed at 35 with colon cancer, then you would start your screenings at 25. You would not wait until you were 35 or 40. But for those who may have a mother or father who was 55 or 58 when they had their colon cancer, well, then they would want to get their first colonoscopy at the age of 40 or 35 years of age. Again, you're always going to go with whatever number is younger. For those who have multiple family members with colon cancer, the same rules apply. Unfortunately, only about 66% of Americans get their colonoscopies that should get it. So while that's better than it used to be, that's up from, I want to say, around 50 or 40% in the mid-90s to up to 66% now. We still have a ways to go. Colon cancer is a very treatable illness. It's a very treatable disease, not only through colonoscopies, but also through some of those lifestyle changes that we discuss, from dietary to exercise, obesity, smoking, alcohol. All of these things and these factors that we can make a change with can have a positive outcome on our incidence of colon cancer. Are there any other questions? All right. Well, thank you guys. It's been a pleasure talking with you. I hope that you've learned something today, and I hope that everyone stays safe and has a wonderful day. Again, I'm Dr. Timothy Adams, and it's been nice talking with you.